So, good evening, dear friends and colleagues. I'm talking from the Netherlands, and my friend Bernard Malavaud is talking from France. Welcome to the Bladder Cancer webinar, which is organized by the European School of Urology. What can you expect? We will have two presentations of around 20 minutes. As you know, Bernard is a urology in Toulouse in France. He will talk about muscle-invasive bladder cancer, and I will talk about non-muscle invasive bladder cancer. After each lecture, there will be around 10 minutes for questions, which you can ask through the question portal. And the webinar is accredited with 1 point upon completion of the questionnaire after attending this webinar. There will be some conflicts of interest, but I will show that later. So, non-muscle invasive bladder cancer, I will summarize the course that we would have given during the normal EAU. So, the plan was to review some guideline topics, diagnosis, markers and treatment with comments, TUR techniques with pitfalls, enhanced imaging, as well as what we do with complications like surgery, videos and cases, complications of intravesical therapy, prevention and therapy of that, the problem of abnormal cytology, including locations of urothelial cancer outside the bladder, and in all that was planned to be 3 hours, 6 presentations, videos, cases by Professors Palau, Bakyuk and myself, and now you're going to get 20 minutes, 1 presenter, no videos or cases, and around 60 slides. So, bladder cancer, everybody's interested in prostate cancer, but is bladder cancer important? I think it's very important. If you look at the cost estimate, the estimate is that it is around 5% of the total healthcare costs, and that's even without the cost of productivity loss and informal care, like your neighbors doing shopping for you, or you're not able to work. So it's very expensive. And is it important? I think it is very important. If you see here, the prognosis, disease-specific survival of a T1 high-grade bladder tumor is the same as a clinically T3B, Gleason 5+5 prostate cancer, 12 out of 12 course positive with a PSA of 75. And with that, because of course everybody says it's a very bad disease, but that's the same disease-specific survival as high-grade T1 bladder cancer. I will first give some slides that Dr. Palau made for diagnosis, markers, and innovations. He does have some conflicts of interest. So the recommendations for hematuria are obviously that you have to do a workup, which means urography in selected cases, namely the high-risk ones. You have to do a cystoscopy, and cytology is also a strong recommendation in high-grade tumors. You can use maybe ultrasound or CT. Ultrasound has a good sensitivity when the tumors are a little bit bigger than 1 centimeter, but in smaller tumors the sensitivity decreases. And the same goes for CT urography. If the tumors are larger, it's definitely good. The specificity is very high, but of course it's a more expensive and a more time-consuming method of detecting that. What about urinary markers at the current moment? For screening, I think we don't have anything yet. As a diagnostic test, some have been used and are used, but it's not a lot. For surveillance, I think some are coming. I'll talk to that a little bit later. And to predict the biological potential, for example, progression, again, we do have some markers, but they're not used in clinical practice currently. What about bladder biopsies and biopsies of the prostatic urethra? Well, prostatic urethra biopsies, you have to take that if there is a bladder neck tumor, if there is CIS present, if there is, of course, positive cytology without evidence of a tumor in the bladder, and if you see something in the prostatic urethra. And if you do that, you have to do a resection, so a warm biopsy. And if you haven't done that the first time, you should consider doing that during a re-TUR. Why is prostatic urethra involvement important? You see here that if you do have prostatic urethra involvement, then your prognosis definitely is worse than without involvement. Here, the slide I promised about urinary markers for follow-up. You see probably some names that you recognize. They are being tested, they are in posters, they are in presentations and in manuscripts. And beware, these will be used in the future to stop or to diminish the number of cystoscopies because they have a very high negative predictive value. What about follow-up strategy? That's again risk adapted. You see that it is based on cystoscopy and biopsies if you see something abnormal. You know that in low-risk tumors that there is a 3-month cystoscopy, and then you do that a few times yearly. Well, on the other hand, you have high-risk tumors which require regular cystoscopy in the first 2 years, every 3 months, and then every 6 months, and then yearly, but you have to do that for a long time, including regular upper urinary tract imaging. And in patients with intermediate risk tumors, you have to do something in between. However, the recommendations for this are not very strong. Next part of our course was how to perform a TURB. And these are the conflicts of Marco Babiuk. A TURB is a very important procedure. It is really surgery. And you have to do that, perform that systematically. It's a complex procedure, and it does not only give you diagnostic information, but it also helps to treat your patient. And you see here a table from the EU guidelines, which give you some systematic information how to perform a TURB. If you do that, you have to use modern equipment, modern telescopes, good cameras. You can use fluorescence cystoscopy or narrowband imaging or SPICE, image 1, which is from Storch. That does give you some enhanced imaging, but in all cases you have to do a correct diagnosis and a complete resection. And the goal of the resection is, like I told you, complete removal of the tumor and to get a correct diagnosis. You can do that by separate resection, so take away the superficial part and then maybe the deeper part, but you can also do that in maybe smaller tumors with an en bloc resection. In any case, think about an individual approach, an individual technique, and use good instruments. Here you see, for example, what you can receive, what the pathologist can receive when you do an en bloc resection, and for pathology this of course is much, much better than all the small bits and pieces that we take out when we do a normal TUR. What to do with tumors at the ureteric ostium? Well, if the tumor is more or less around the ostium, you don't really have to do urethronoscopy. Do an adequate tumor resection. Be careful with coagulation, that will give you some fibrosis. And after you've done a superficial resection and there is no tumor in the ureter, no stent is needed. However, if there is distal urethral involvement, then resect as deep as possible. Be aware not to detach the ureter. Put in a stent after deep resection and consider a re-resection or a urethronoscopy in a second procedure. What about the re-TUR? The guideline says that you have to do that in all T1 and high-grade tumors. You have to do that 2 to 6 weeks after the initial TUR. Why do you have to do that? It can really detect residual tumor. You see here that it is around 50%, but it also can detect a T1 or a T2 tumor. So there is upstaging. The staging error is again a few tenths of percent. So that's important. And if you want to know everything about TUR and non-muscle invasive bladder, you could go to an ESU masterclass, which we do yearly in Prague. So hopefully, again, we will do that next year. Then we will go to treatment. And again, treatment is risk group adapted. I have some conflicts of interest which are not relevant for this lecture. You probably know the risk groups from the guideline. You have your low risk group, which is primary, solitary, TA low grade, small, without CIS. Then you have high grade, which basically is T1 or high grade or CIS. And then a very small group of multiple and recurrent and large TA grade 1 and grade 2 tumors. I think that's a very small percentage. And intermediate is actually all the rest in between. Then in the EU guideline, we have the highest risk category. And again, also in this case, the strength rating is strong. And the very high risk patients are those with T1 G3 with carcinoma in situ, recurrent or large T1 G3s, G1 G3 with CRS in the prostatic urethra. We already mentioned that. Some forms of variant histology in the bladder and lymphovascular invasion. What can you expect from these high-grade patients? Well, these are the updated EORTC nomograms where patients were adequately treated with 1 to 3 years of BCG. And in the lower part of my slide, you still see that 1 and 5 year progression rates are 10 to 20% after 5 years. So this really is nasty disease. Additional factors that are not very good for the prognosis, as I already told you, lymphovascular invasion and CIS. But something that you can actually just ask from your pathologist is the fact whether it's a small T1, a superficial T1, or a deep invasive T1. That's a really important risk factor for the prognosis. So an extensive or advanced T1 versus a superficial or non-extended T1. And there are several manuscripts that have looked at that. Once we have treated the patients, we've done a TOR, we know the risk profile we have to treat. So for low risk, the treatment recommendation actually is to do one immediate installation with chemotherapy. It's a strong recommendation. And you should do that or the day of surgery or at the next day, basically as soon as possible. And you see that Richard Sylvester a few years ago did an update of a systematic review and found again in a large group of patients that the reduction of the 5-year recurrence rate with only one installation is around 15%, from around 60 to around 45%. And that's not only clinically significant, but definitely also very relevant. However, it's only in the real low-risk cases. So basically, this is a strong recommendation in the guideline. Is it done? It is not always done. Sometimes for the right reasons, if you think you have a perforation, sometimes for the wrong reasons. There are really still urologists that don't believe it helps. But in any case, it is a very safe procedure. Are there alternatives? Yes, there are. What has been published a few times is continuous bladder irrigation with saline for 24 hours. I do that, for example, in patients that have allergia to chemotherapy, like mitomycin C or eberubicin. You can do active surveillance in case of a low risk, and you can also even do office fulguration. This is a new statement in the 2019 EU guideline. So for these low-risk patients, there are a few realistic alternatives. What about intermediate risk patients? Also, again, one installation, but that has to be followed by chemotherapy or BCG, and that's around 1 year. And whether you choose for chemotherapy or for BCG depends, of course, on availability of BCG, and also BCG has a little bit more toxicity. It is, however, also a little bit more effective. The comment of Professor Babjuk is that in case of BCG shortage, mitomycin C is a very valid alternative, and in case of mitomycin C shortage, eberubicin, which has been a little bit shown less than BCG, might be an alternative because it has been never compared to mitomycin C. So keep that in mind. We don't have a shortage currently in the Netherlands, but I hear from several countries that there are problems with BCG and also with mitomycin C. What about the high-risk patients? Well, I think that's quite obvious. Those patients you have to treat with BCG maintenance, and that's a very strong recommendation. Although the benefit of the second and third year should be weighed against the costs and the inconveniences. And one of the reasons is that this group is very heterogeneous. What can you expect with 1 or 3 years of treatment? You'll see a very large EORTC study, which is around 1,500 patients. And if you see the comparison between 3 years full dose, 3 years 1/3 dose, 1 year full dose, and 1 year 1/3 dose, you see that with the lowest dose and the lowest schedule, there is a higher recurrence rate, but the difference is only around 10%. And there is no difference in progression. There is no difference in cancer-specific mortality. And surprisingly, there was no difference in toxicity. So that means if you go down in this schedule, you will have a little bit more recurrences, but it's not very dangerous. Beware, 1 year, 1/3 dose is not recommended in the guideline. Is the intensity important? Yes, it is important. There are 2 studies that have shown that you can't go very low. The Kuwaiti group has used BCG maintenance with 1 induction course every time and not 3. And there you see that it is not more effective than only the induction course. And the Nimbus trial, where they compared 3 BCG installations as induction with 6 installations, showed significantly less efficacy of the reduced dose. So don't go too low in intensity. Does the strain matter? Probably yes, because if you see the schedule on the right upper side, since 1921 there have been several strains that have been cultured worldwide, so there have to be difference between these strains. There have been 2 studies that showed indeed a difference. One study compared types with IRBM BCG, one study compared types with Connaught BCG, and both studies suggested, they were not really powered for that, but still, they suggested that types was a little bit less effective than the other 2 strains. Connaught, by the way, is not available anymore. What about the highest risk group? The recommendation is that a cystectomy should definitely be discussed with your patient. It's a strong recommendation. And the same goes for BCG failures. Again, also the recommendation is to perform a radical cystectomy. What are BCG failure guideline mentioned alternatives? Well, you can use intravesical chemotherapy. For example, the combination of gemcitabine and docetaxel is used quite a lot in the United States. And in May of this year, in the Journal of Urology, there was a nice manuscript on that. Then one of the alternatives is microwave-induced chemohyperthermia. Personally, I use that a lot, and the results are definitely not very bad. So if you have a center nearby which has microwave-induced chemohyperthermia, it's definitely something to consider. EMDA has been used. There was a nice review in 2017 showing that the data are very limited. And of course, it's not only EMDA, but it's a combination with BCG. And finally, if you have a trial with one of the new drugs, immunotherapy trials, like the Keynote 57 trial, would be interesting to put patients in those trials because we know that bladder cancer is very sensitive to immunotherapy. And this is something new. I'll talk about that Saturday during the virtual EAU Congress. Insiladrin is a virus which actually, if it is given, goes into the cellular DNA and provides the cell to make alpha interferon 2b. And the phase 3 results are really very good, 50% complete response, of which half of those patients remains in response within a year. And this drug is currently being looked at by the FDA for approval. What about complications of intravesical therapy? Intravesical chemotherapy has some general toxicity like cystitis, urgency, nocturia, and hematuria. We all know that as urologists. And there is some specific toxicity. Mitomycin C can cause some flu-like symptoms, skin rash, and allergia, which you see in around 10%. And if you have allergia, you definitely have to stop with mitomycin C. Gemcitabine has some nausea, which the other drugs don't. Doxorubicin is potentially cardiomyopathy, and docetaxel sometimes gives alopecia. So there are some general and some specific side effects that you can see with intravesical chemotherapy. What is the treatment? Well, if it's mild, you can use anticholinergic drugs and analgesics. You, of course, can delay the instillation if the symptoms are still present. And in severe cases, stop your treatment, use steroids or orally, or you can give an interpulsor corticosteroid injection, which might be helpful to reduce the complaints. What about data on BCG side effects? Well, if you look at current series, then the grade 3 and 4 toxicity is very, very limited. And you see other side effects in 10 to 20% of your patients. And again, mostly are related to the bladder, of course. You do not need symptoms and side effects to get a benefit, as been shown by Richard Sylvester. There have been some deaths attributed to BCG, but almost always associated with a traumatic cauterization. And if you want to know everything about side effects and how to treat them, there is a very nice table in the EAO Non-Muscle Invasive Bladder Cancer 2020 guideline. Recognition and management of these BCG side effects. Again, if it's mild, you can use anticholinergic drugs or analgesics. Make sure that you exclude a normal bacterial urinary tract infection and delay BCG for 1 week. If it's more severe, you can use fluoroquinolones or anti-tuberculostatic drugs, and even, of course, in the worst case scenario, when patients are on the ICU ward, you have to use systemic steroids. These can be life-saving. Can you prevent BCG toxicity? Of course, to reduce the amount of BCG, the dose reduction, stop maintenance earlier, decrease the dwell time, or shorten the maintenance schedule from 3 to 2 treatments, or maybe antibiotics. INH does not do the job, has been shown in a very large EORTC study. Ofloxacin might do the job. I give that on the evening of the BCG installation and the next morning, and it does reduce the side effects. Contraindications for BCG are, of course, let's say, traumatic catheterization and allergia. Relative contraindications are immunocompromised patients, like, for example, kidney transplantations. It's a relative contraindication, and prior tuberculosis. And finally, what do we have to do with abnormal cytology, including locations outside the bladder and its limitations? Realize that cytology is very subjective, so know your center's data. Know your center's sensitivity and specificity of an abnormal cytology result. And beware of abnormal cytology results in case of intravesical instillation therapy. That might be false positive. But if you have persistent abnormal cytology and a negative evaluation, usually you will find in the relative small, quick future urothelial carcinoma. Treatment of CIS and prostatic urethra is to start with TURB, and then you can really treat with BCG a lot of those patients adequately. And even if you have prostatic duct involvement, still BCG is effective in 3/4 of your patients. It's an older study of Professor Malavaud, but beware of understaging. And if you have a recurrence or if you have stromal invasion, then make sure that you change your profile and go to cystoprostatectomy. What about upper tract urothelial carcinoma in case of primary non-muscle invasive bladder cancer? With the primary diagnosis, you don't see it that much, around 1%, and the risk factor actually is only trigonal tumor or trigonal CIS. In follow-up, you see it a little bit more often, and the risk factors are high-grade bladder tumors, bladder CIS, patients even after cystectomy, and if you have had reflux, that increases your risk around 10-fold. So during follow-up, if you have positive cytology and no visible tumor, think about extravesical locations. Otherwise, you do mapping biopsies or use blue light to find any abnormalities in the bladder. This is my last slide. These are the take-home or stay-home messages. Do not underestimate the importance of bladder cancer, both costs and prognosis. Evaluate the prostatic urethra. It's very relevant for prognosis in high-risk patients. Do a good personalized TOR and or a re-TOR with adequate equipment. It's a real operation. Know the risk groups and their treatment, but also know the limitations and the alternatives. For example, continuous irrigation, active surveillance and filtration and low risk, gemdosi, hyperthermia, EMDA, the virus or immunotrials in high risk. Recognize toxicity of mitomycin C and especially BCG and know prevention and treatment. Think about abnormal cytology and a normal bladder. Beware of the prostatic urethra and the upper urinary tract. And finally, for follow-up, urinary markers definitely are coming. So I'd like to thank you for your attention, and then hopefully, Bernard, there are some questions.
Yes, indeed, I've received quite a few questions. Some relates to BCG. Do you know any predictors of efficacy, of BCG efficacy that could be obtained from biopsy of the resection specimen?
Sorry, I didn't understand that well.
Do we have any predictors of BCG efficacy that we can obtain from the biopsy or the resection specimen?
To be honest, for let's say normal clinical practice, I don't think so. There have been studies looking at, for example, cytokines in the urine or cytokine profiles in bladder biopsies, which apparently give you some impression whether patients have responded to BCG or will respond to BCG. To be honest, I think for current practice, that's not something we can use. It's a question of trial and error. So basically the answer is no.
Good, very straightforward. One question about the safety of BCG. Do we need to do some tuberculosis test before undergoing BCG treatment in the patients? Is there any value?
Not for safety. I wrote my thesis on BCG in 1992 when all the patients that I treated before that actually must have had tuberculosis in the Second World War, because we tested those patients and we didn't find more toxicity. There's now, as you know, a trial in the US looking at the effect of the intradermal inoculation to see whether the BCG then is more effective, because you maybe have a better boost of the immune system. So with regard to safety, no problem. With regard to efficacy, maybe. We have looked at that in the 90s. We didn't find that, but there is currently a US trial again looking at that question. Does a intradermal BCG gift improve your efficacy?
Well, now we have an avalanche, proper avalanche of questions about BCG, but let's switch to the prostatic resection that you advocated in case of CIS inside the prostatic urethra. One very practical question is, what is the extent of this resection? What do you recommend in terms of extent? Should we go deep? Should we remain superficial? How do we do that?
Okay, so if I normally take biopsies from the bladder in the CIS patients, I take two warm biopsies at 5 and 7 o'clock in the prostatic urethra, and that is the chip that you normally have with the TURB. Then you certainly have some stroma, you have some ducts, so that should be normally enough. The other thing is, if you have found CIS there and you want to treat the prostatic urethra, basically it's not a question of resecting more, but it's a question of opening the bladder neck. So that means that you have to do a resection of the bladder neck and the beginning of the prostatic urethra, just to make sure that your installation also reaches the prostatic urethra. So that's not a question of, at the apex resecting a lot. No, it's the base of the prostate, the bladder neck, which has to be resected.
Okay, many thanks. Another question that comes quite often is, how do we assess the risk stratification of G2 lesions compared to high risk or intermediate risk cancers? Those two WHO classifications, which are a bit confusing sometimes. How do you do?
Well, you see, since we have used the newer classification, where you actually force the pathologist, well, you can't force the pathologist, of course, but you really want to know from the pathologist whether it's low grade or high grade. We would really love to have low grade and high grade. And you see that many former grade 2 patients have gotten in the high grade group. And I seldomly get from my pathologist currently the diagnosis intermediate grade. Sometimes he really doesn't know. But to be honest, I would advise you to really ask your pathologist to take a decision. And in case of doubt, I would stay on the safe side and treat it as a high risk patient, as a high grade patient.
Good, that's a very straightforward answer. One question that comes also quite often, it is about mitomycin C use. There are different schedules and regimens, and which one do you recommend? 6 courses plus maintenance, 8 courses, no maintenance? Many questions.
Bernard, that's a question that comes up at every course I give, and the answer is quite simple. I really haven't got any clue. I've been trained with 4 weekly installations and 5 monthly installations. That's half a year. And that's what I do already for 20 years. But I know there are many, many schedules. We looked at that with Richard Sylvester. We looked at what you should not do. And for example, if you give intravesical chemotherapy longer than 1 year, that doesn't really help a lot. So I guess the optimal schedule is somewhere between 6 and 12 months. And whether you do that every month or every week, or I really don't know. I'm very happy with the schedule that I use, but I know that there are a lot of different schedules. And again, I use 4 times weekly and 5 times monthly. That's 6 months, that's convenient. What's your schedule?
Well, actually, it's 8 weekly schedules plus 1 every month for 6 months.
So that's almost the same, yeah.
Yeah, definitely.
Yeah.
So maybe one last question. Do you believe there's any role for gemcitabine installation in high-risk patients? We discussed epirubicin, mitomycin C, BCG, Taxan and Taxol, paclitaxel. What about gemcitabine?
Well, we have used that in the Netherlands in the former BCG shortlist periods. I think that was 2014 or 2015 as a potential alternative. There have been some studies that have shown that gemcitabine is effective. Currently, I'm quite charmed by the schedule that has been used in the US, and it's used quite a lot because in the US there really is a large BCG problem, and that's a combination of gemcitabine and docetaxel. And it's actually what I hear from the US colleagues. I have never used it myself, I have to be honest on that. But what I hear from them, it's only 1 gram of gemcitabine and 37.5 milligrams of docetaxel. So it's less gemcitabine. We have used 2 grams in the Netherlands, which is quite severe. It's a little bit toxic for the bladder. But apparently, if you use 1 gram and combine it with docetaxel, it's quite easy to handle by the patient. So maybe that's a realistic alternative. And depending on the availability of BCG, the future will learn. But we have to realize that gemcitabine is an effective drug for bladder cancer, so it doesn't sound that bad.
Okay, I think you must be congratulated for squeezing into 20 minutes a 3-hour course. Let's see if I can manage to do something approaching your performance.
Okay, good luck, Bernard.
Thank you. Time to move to muscle invasive bladder cancer. I have the conflict of interest, and usually this is a course that we give Maximilian Berger and I during the EAU Congress, and next year you're all welcome to come and enjoy the friend and enjoy. So, the fact about muscle-invasive bladder cancer, it is that there are many directions, many obstacles, many information, and we have to find a way into this forest of information. So the key word in muscle-invasive bladder cancer and metastatic bladder cancer is, to my understanding, personalization. That is characterization of the disease, of the patient, informing the patient, optimizing the surgical environment, and of course, individualizing the management of metastatic bladder cancer. So let's start with the characterization of the disease. We have some information suggesting that imaging, possibly, and genomic and molecular, certainly, are maybe of use in this endeavor. We have those two papers recently published in European Urology showing that MRI may have come of age in bladder cancer. We don't know yet whether it will be helpful or not helpful, but definitely there's a presentation, there's some terminology that is coming out with this VIRADS classification, and it's possible that potentially it might help us into better characterizing the lesions and therefore optimizing the treatment. What is certain, on the other hand, it is that bladder cancer is one of the most active field of cancer biology with very high impact factors papers. This one was published in 2013 in Nature and showed that there was a very high prevalence of somatic mutations in bladder cancer. Very, very high, which already eroded and suggested that immunotherapy could be of use in this disease. You might notice that just beside bladder cancer, on the right-hand side of the slide, you have lung adenocarcinoma, lung squamous carcinoma, and melanoma, which are the four best indications for immunotherapy apart from bladder cancer. Second, we have gained knowledge about the different variety of bladder cancer. And this one comes from Nature 2014, and it showed that there were mutation, copy number alterations, and that we could actually subdivide muscle-invasive bladder cancer in different entities. Those different entities will bear the hallmarks of the luminal layer of the urothelium or the basal layer, plus or minus some immune response. Basically, it would lead us to 4 separate kinds of cancers: luminal, basal, indifferentiated, and luminal immune cancers. This is quite important because the molecular subtypes in the next future will provide the rationale for precision medicine muscle-invasive bladder cancer. For instance, we already have some targeted treatment against FGFR3, which were recently approved by the FDA for muscle-invasive bladder cancer. And we also have some drugs that can target some basal markers. But in addition, there is some strong connection between the different molecular subtypes and the response to the emerging immunotherapy in bladder cancer. So we should stay tuned to this molecular dissection of one of the most complex diseases in oncology. Speaking from a surgical point of view, biology might also explain some intriguing results after cystectomy. And we have all known for many years that cancers, muscle-invasive cancers that were immediately detected and operated had a better prognosis than those who had progressed toward muscle invasion after being non-muscle invasive. And it was a bit complicated to understand why a T2 lesion would be different in terms of prognosis, depending on the previous history of the patient. And actually, there we have a strong biology connections and with some molecules that are involved in DNA repairs and which are actually associated with a higher sensitivity to cisplatin. There we are introducing the concept of cisplatin sensitivity, which is one of the main axis of the management of metastatic and muscle-invasive bladder cancer. So having characterized better, understood better the disease, we also have to understand the patient. And two questions: is it fit for cystectomy? Is it fit for cisplatin-based chemotherapy? Fit for cystectomy is not an easy matter, and this actually I have to pay my respect to the chairman of the muscle invasive and metastatic bladder cancer guidelines committee of the EAU, that is Fred Witjes. And in these recommendations, we are strongly enticed to analyzed, to refine our understanding and our analysis of the general status of the patient. But to that end, the question and the limitation is that we don't have the proper instruments for that. Of course, we have the Charlson Comorbidity Index that relates to perioperative mortality, the overall survival and cancer-specific survival. But when we look at how the performance, the predictive performance of all the indexes, including the Charlson Index, well, actually, they are not too good. And not too good in terms of predicting the 30-day mortality or even in terms of predicting the Clavien-Dindo 4 complications. So I like this conclusion that prediction is difficult, and especially about the future. And definitely the way the operational way to evaluate patients prior to surgery is not yet fully available. I like very much this paper because it shows that we already have some information at hand that we are not using at their full value. And one of those is sarcopenia. The quantity of striated muscles in a patient strongly relates to complete cancer-specific mortality and also to overall survival. So we should not abandon the idea of predicting better from the patient the aggressiveness of the disease. Second question, how can we know and can we evaluate whether the patient is fit for cisplatin? Cisplatin is the spine of the treatment, the medical treatment for muscle invasive and metastatic bladder cancer. So we are to know and to use and to select patient for cisplatin. And those criteria that allow us to select the patients are in the number of 5. They should be in good performance status, PS0 performance status 0 or 1. You should have a good glomerular filtration rate, no audiometric loss, no peripheral neuropathy, and no heart failure. And those criteria are valid not only for muscle invasive, neoadjuvant, and adjuvant chemotherapy, but also for metastatic bladder cancer, because they will allow us to use the most effective agent at hand, which is cisplatin. The third aspect is to inform the patient. And this is a complicated, complex endeavor. We have to inform him about, or her, about the survival of this specific disease, the quality of life that he can expect from surgery, for instance, and also for alternative treatments. Let's look at the benefit of cystectomy. There is no doubt that it is a very solid benefit. It ensures adequate local control in organ confined extravesical disease, and also to some extent in patients with limited lymph node extension. But it also entails survival. But this survival strongly relates to the fact that the patient is organ confined, 80% survival at 5 years, or extravesical disease. 60% of the patients with extravesical disease are still alive 5 years later, not only because of surgery, but also because of the medical treatment that can be offered to them later, and also in a small minority of patients for extravesical disease. So surgery is a very effective tool in the armamentarium of muscle invasive bladder cancer. But this tool comes at the cost of significant risk of death. And we have to acknowledge that we are not yet fully mastering this aspect of the treatment. The overall mortality is roughly in the range of 5 to 10%. Besides mortality, we also have morbidity, with a minority of patients experiencing significant morbidity. And I like this very much, this paper, and this is one that was selected by Professor Berger because it's an honest review of patients in a single institution that were prospectively followed up for over 10 years. And it showed that irrespective of the kind of urinary diversion that we used, should it be a continent cutaneous diversion, a neobladder, or what they call a sexuality preserving continent neobladder, well, actually, the continence was not an issue. Roughly speaking, over 90% of the patients are continent at daytime and over 85% at nighttime. So it's a significant surgery. It has to be approached with caution, but the consequences on continence of the diversions are fully mastered by the surgeons at the time. However, we have to acknowledge that although cancer-specific mortality is a principal cause of death in muscle-invasive bladder cancer, up to 30% of the death in older patients come from other causes, meaning that when you are 80 years of age and you have PT2 anterior lesion, this is presented in red, the risk of dying is at 5 years is very high. You're old. But other causes than cancer still play a significant role. So can we manage cancer in old and frail patients without impacting too much the other causes of death mortality? We have what is called the Trimodality therapy. And this Trimodality therapy has been ongoing for over 20 years since the Shipley seminal paper. And they definitely shows that compared to cystectomy, it works. It works not as well, but for, let's say, 5 years, if you take the 5-year time limit, well, you get comparative results. So in an old or frail patient, it's a valid option and shouldn't be undervalued. One limitation of the trimodality therapy is that there are many ways to apply it in the real life, and therefore the literature is not as strong as the one that we can get from surgery. These are the recommendations from the EU. Radical cystectomy is recommended, of course, in T2, T4, N0, and high non-muscle invasive bladder cancer, but we can also offer multimodality treatment as an alternative. 4, we should optimize the surgical environment. That means the preoperative chemotherapy, the surgical technique, hospital volume, and early rehabilitation. The recommendations are, and this is strongly established in the SWOG report in 2003, is the recommendations are strongly to offer neoadjuvant chemotherapy for any patient who is fit for cisplatin-based combination therapy. However, this is not always applied, and there are some real-life reports that still question the benefit of neoadjuvant chemotherapy, not in high-volume muscle-invasive bladder cancer, but in low-volume muscle-invasive cancer. And this was actually already alluded in the initial seminal Grossman paper. So one question that we might ask ourselves is it possible to anticipate the benefit of neoadjuvant chemotherapy? Can we do that by imaging? Do we have any biology markers? Imaging might be one way to go, and MRI could actually play a role because the apparent diffusion coefficient inversely correlates with cell divisions and also might predict the sensitivity to cisplatin-based chemotherapy. It's a promising field of research. It is not a tool that we can apply today and is not by far stabilized. Do we have any biology in store? Well, actually, this is a review paper published just this year, showing that despite the many different directions of studies, cell survival pathway, DNA damage repair, membrane transporter, and others, well, actually, we don't have any good predictors of a cisplatin response. So, if we don't know exactly whether it's useful or not useful prior to surgery, at least for small T2 lesions, for instance, Can we readjust our options after the surgery and therefore offer adjuvant instead of neoadjuvant chemotherapy? Definitely the answer is yes, because we have a large body of research showing that when neoadjuvant chemotherapy was not offered to the patient or could not be offered to the patient, actually post-operative adjuvant chemotherapy showed a strong benefit compared to simple observation. So the guidelines at the moment had to the strong recommendation of multimodality cisplatin and neoadjuvant chemotherapy, had the offer of adjuvant cisplatin-based combination therapy in those who did not receive neoadjuvant chemotherapy prior. Let's discuss a bit about the surgery. This is usually the field of medicine that we know best. And one controversial issue is how do we do the cystectomy? Open cystectomy, radical laparoscopic cystectomy, or robot-assisted cystectomy. And this paper, which came in complement of the RAZOR study that was published in the Lancet 2 years before, definitely shows that whatever the technique, the results are somewhat the same. What is slightly different is actually the operative time that is longer with the robot, but this comes with a benefit in terms of lower blood loss. And we know that transfusions is a bad thing in cancer biology because it does impact the overall survival, surprisingly enough. It improves the length of hospitalization and also improves the number of lymph nodes that are harvested at the time of surgery, which also relates to survival. So the recommendations are to inform the patient of the advantages and disadvantages of open radical cystectomy and robot-assisted radical cystectomy, and of course, to select those centers that are capable to set that up. And this comes to one of the very high and important aspects of the management of muscle-invasive bladder cancer. It is that it should be done in centers with a high volume of patients. There's no doubt that there's a limit, an annual limit between 20, 30 cases per center that should be the target for being qualified to offer this surgery to the patients. Okay, we have a good indication. We offer preoperative chemotherapy, and now we have the patient has received information and gave his full informed consent. So we have to prepare the patient for the surgery. And there's a very strong body of evidence about what we call immunonutrition. And this immunonutrition was shown in all major surgeries to be beneficial for the patient, not only in terms of morbidity, post-operative morbidity, but also in some papers in terms of long-term survival. And this immunonutrition should come in complement after surgery with what is called early rehabilitation. Early rehabilitation is a must in all major centers who deal with major surgery. We all have our different protocols, but they all relate on the lower use of analgesic, early bowel, early alimentation, and advancing how would I say that? While showing overall intake of fluid and then of light meals. Last, the individualized management of metastatic bladder cancer. We discussed prior how do we identify a patient to be fit for cisplatin, but 50% of patients are not fit for cisplatin, and those are actually nowadays offered immunotherapy, which were developed to answer the unmet needs of this fraction of population. If you look at the literature and at the clinicaltrials.gov, there are many trials ongoing in that direction. It's a very, very active field of medical oncology. And there's no doubt that in the very next month and years, we'll have more and more drugs in that immunotherapy drugs that will be offered to our patients in very complicated, in select situations. One limit to this development of drugs is the cost of those, and it's not rare to have an immunotherapy drug to cost roughly 4,000 to 5,000 euros a month. Okay, so we know that this patient is not fit. We know that some patients are fit for cisplatin. They receive cisplatin-based combinations chemotherapy. The overall survival after in that setting is 12 to 16 months. But can we do better? And can we do better in light of the modifications that are induced by chemotherapy? We initially discussed the fact that there are many molecular variants and variations in bladder cancer. Those variations are also observed in metastatic patients receiving chemotherapy, and actually the chemotherapy would appear to accelerate those variations. Therefore, if those variations in the molecular subtypes are somewhat related to the immune surveillance, can we redress the cancer recurrence by immunotherapy? At the moment, the main predictors of response are lymph node metastases, which are good indication for chemotherapy and also good indications for consolidation treatment, surgery, removal of one single metastatic lymph node, possibly radiotherapy. But there are also patients who responded to the chemotherapy are also good indications for what is called switch maintenance immunotherapy. And this is a Javelin study, which was just presented at the ASCO 2020 meeting, that shows that one patient who responded initially to cisplatin-based chemotherapy to had avelumab later on in the course of the disease would actually increase the overall survival in a very significant manner. So this would be the take-home message. Characterization of the disease, don't forget imaging and biology. Characterization of the patient, is the patient fit for cisplatin? Is he fit for surgery? Information, discuss about survival, quality of life, the options of bladder conservation. Optimization of the surgical environment, perioperative chemotherapy, hospital volume surgical technique, and early rehabilitation. And of course, in the individualize the management of metastatic bladder cancer with the emerging role of immunotherapy in cisplatin and fit muscle metastatic bladder cancer patients, and also the switch maintenance immunotherapy. Good. So this is a very simple way to say it. Non-metastatic muscle invasive bladder cancer is a lethal disease, and treatment must be personalized. Any questions?
Bernard, thank you very much for an excellent lecture. I will shoot right away because I had a lot of questions here. One which is, I think, hopefully easy to answer. If you've got an invasive bladder cancer with CIS, would you recommend radiotherapy or not?
No, I will not recommend. I don't see myself well. Okay, the indications for bladder conservation are, to my understanding, a low volume, small, what I call it small T2 lesions with no CIS within the bladder, and as it is a small T2 with no upper tract dilation. So when you have all those, and that is last, and the lesion should be in a position within the bladder that can be fully resected or aggressively resected. So these are the conditions. No CIS, small T2, no upper tract dilation, can be fully resected.
I totally agree. You said, trimodality treatment might be something for the frail patients. Would you consider that in a healthy 65-year-old male, or if you would ask that?
Okay, that's a very tricky question because, to be frank with you, yes. And I know it's very heretical, but I think that a small T2 lesions that has been fully evaluated by pre-TURB MRI, which shows that it's a mild lesion with no retraction of the fat, that is, say, somewhere in the trigon that can be resected deep. I think we have enough evidence to show that chemotherapy plus radiotherapy in that setting offers at least 5 to 10 years survival potential similar to surgery. What's your opinion? You are the chairman of the guidelines. Tell me.
Well, I really think you're right, Bernard. And I see that trimodality treatment or bladder preserving treatments are becoming more and more popular. Yeah. So I think that's right. You mentioned MRI. Do you use MRI in your current practice to image invasive bladder cancer?
Well, I mentioned the Valeria Panebianco paper and the Witjes papers. actually, they found a very astute way to demonstrate the benefit of MRI, because it just wanted to analyze whether it would highlight muscle invasion or not, which is not, to my understanding, the main question. The main question is, can we use MRI in a way that will offer additional information in, for instance, bladder preservative management? And that's not the answer there. That's not the question they answered. So yes, I do use it, not for the benefit of the patient, but for my own benefit, because I want to make my own opinion in that direction.
Okay. So there was one interesting question, which I've been asked more often. You've done a cystectomy with neoadjuvant chemotherapy. The bladder is negative, T0, but you still find nodes. What are you going to do?
Oh, okay. Well, actually nothing. If you have removed the nodes, you don't do anything more, but you just follow the patient. And the question is, how do you follow? Well, first, there's a question of the number of nodes that you have removed. Second, which kind of extension within the lymph nodes? Do we have extracapsular extension across beyond the capsule of the lymph node? But and then two direction. You have a bulky lymph node involvement, and you might, but the metastatic workout is negative, and you might want to discuss radiotherapy, because this is a traditional way to use not adjuvant, but postoperative radiotherapy. Or you just have one single lymph node with one emboli in it. And in that case, patients should be followed and treated according to the result of this follow-up.
Okay, agree with that. Bernard, there's a question from Mexico from my great friend Arturo Mendoza Valdez about PET-CT. And you know, it's not in the guideline, but where do you think the places for PET-CT for initial imaging and also to follow up neoadjuvant chemotherapy?
Okay, I know it's not in the guidelines, and this may be one slight point with the guideline to which I disagree. I think FDG.
We're going to address that next year.
We'll see. But we do use it extensively. Yes, in any patient in whom we believe there might be a high risk of metastatic spread, we tend to use it. And the question is, what do we do with the information that they bring? Do we say, for instance, that you have a large, bulky, muscle invasive bladder cancer, you do the neoadjuvant chemotherapy. There is no point in doing the PET-CT scan at that time, but imagine that you still do it after the chemotherapy and you find some faintly positive lymph nodes at the renal ileum. Will you abandon the project of surgery? Certainly not. The PET-CT scan in the setting of patient who is already within the process of getting a surgery, it doesn't make a lot of sense. On the other hand, it makes a lot of sense in a patient who has been operated, and 1 year later or 6 months later, you find some lymph nodes in the pelvis. Okay. The lymph node dissection was not extensive, and you say, well, maybe I could do some salvage treatment of those, surgery or radiotherapy, but where does it stop? And in that setting, I think PET-CT scan is very valuable.
Okay, so more on follow-up. The comment of Arturo is, by the way, that they've been using it successfully in clinical routine. So. Sure. Quickly, a question: is there a place for partial cystectomy in muscle invasive bladder cancer?
Sure it does. Yeah. For instance, we discussed the frail patients and conservative management. Conservative management is based on extensive resection chemotherapy, either cisplatin-based or radiosensitizing chemotherapy and radiotherapy. There is for instance, a patient who is 75-year-old with a lesion of the dome, which is a T2. You cannot, or T2 or T3. You cannot resect it deep because you're a bit afraid of getting into the peritoneum. You can do. There is no CIS within the bladder. The rest of the bladder is clean and healthy when you do your cystoscopy. This is a good indication of partial cystectomy of the dome. plus or minus the chemotherapy and radiotherapy. Yes, there are indications for partial cystectomy.
Okay. Well, to be honest, I would basically only consider that in a tumor in a diverticulum. Otherwise, I would be reluctant to do partial cystectomy. Okay, last question, Bernard, because we are running out of time. They all thanked us for wonderful lectures. What would you be consider the time frame between neoadjuvant chemotherapy and cystectomy? How much time do you wait?
Okay, the shortest possible, but doesn't make a lot of sense, because to my understanding, there are not any strong piece of literature showing that 1 week is worse than 2 weeks and 3 weeks. So usually what we do, we wait until the blood test returns to normal after the chemotherapy, meaning 4 to 6 weeks at most.
Yeah, we do the same. Okay. Okay, Bernard, thank you very much. And maybe you can end the session.
Good. Thank you.
Okay, we'd like to thank all the... Yeah?
Okay, I'm doing that, but I'm trying. So, my friends, many thanks for joining us tonight. I noticed during the talk, Fred Witjes' talk, that up to 575 people were on air. So I think it's somewhat of a success. I don't know during my talk if that many people stayed, but anyhow, I want to thank you very much and to say you next time.